I'm Dr. Daniel Kantor, Neurology in Real Time, and I'm so excited to be joined today by Dr. Prashanth Rajarajan. Now, Dr. Rajarajan is actually a resident. In residency in neurology, you start with internal medicine, and then you do 3 more years of neurology. And he's at an institution you may have heard of. It's called Harvard Medical School. Thank you so much for joining us.
Thank you so much for having me.
You will be presenting at the biggest meeting of the year in 2 days to the most people that have probably ever been to a meeting about a certain topic. Tell us more about the topic.
Yeah, absolutely. So what we're going to be presenting on is initially looking at a study assessing neurologic outcomes in patients with multiple sclerosis that get this newer line of cancer treatment called immune checkpoint inhibitors, and looking at are they at higher risk for relapses or other adverse events or bad side effects affecting the nervous system.
So these are people who have multiple sclerosis, and on top of it, they not related to the MS, they develop cancer. And
That's right.
so after chemotherapies, or even sometimes now before, they use these new medicines called ICIs. And I think all of us have seen television commercials. I think Keytruda is one of them where we see that. What makes these medicines special? Like, why were you trying to look at them?
Yeah, I mean, they have a very unique way in which they act or try to help fight the body fight the cancer. So naturally, our immune system has this ability called the checkpoint system. Basically, it prevents our body's immune system from going haywire and attacking things it shouldn't be, holding things in place or in check, right? And the tumor cells are pretty smart, and sometimes they leverage this for their own benefit and keep these immune cells that could be attacking the tumor itself quiet. What the immune checkpoint inhibitors do then is direct antibodies against some of these targets that then allow the immune cells to be active and then actually go attack the tumor itself, with the idea of it then clearing that tumor. In a sense, it unlocks our immune system, right, which comes with the benefit of attacking the tumor, which is not part of us.
Right.
But there's the hypothetical and, in the studies we've seen, very real risk of it attacking other parts of our own body as a side effect.
I think some of this might be new for people. People are used to hearing about the immune system, and we're used to hearing that it's basically the way we battle outside invaders like bacteria, viruses, fungi, and sometimes it gets directed against yourself. When it attacks your skin, we call that psoriasis. When that attacks your pancreas, we call it diabetes type 1. And when it attacks your central nervous system, we call that most commonly multiple sclerosis. But there's something else the immune system does. The immune system doesn't just fight off foreign invaders, it also fights off when our body gets haywire. That's basically what happens in cancer, right?
That's right. Exactly. So, I mean, cancer cells often present with, antigens or the particles that the immune system recognizes as not itself. Sometimes those are shared with our own body, sometimes they're not. And this is where it gets kind of a bit complicated, but what these new lines of treatments are trying to take advantage of in helping our own body try to fight the tumor itself, with some unwelcome side effects, unfortunately, at times.
And I guess the question about MS was because MS we think of as an autoimmune disorder. So if it's already autoimmune, do you want to give a medicine that's going to potentially attack your immune system even more? And maybe what's going to happen is you'll have actually MS relapses.
Absolutely. So that's the
Is
crux.
that what they found in the past? Like when they did the big studies on
Yeah.
ICI?
So that's certainly the crux of the question, right? So you have already, these are looking at patients with underlying autoimmune disease. And, if you think about it hypothetically, if you unlock the immune system and if they already had this predisposition to attack their own body, then you might be making that worse. Interestingly, or unfortunately rather, the initial trials looking at these medications excluded patients with multiple sclerosis. So we actually don't have the best data, looking prospectively. So starting everyone at the same time on this medication and seeing what the effects are in this crucial population. And, this is really important because as patients with MS have increasing treatment options and we're getting better and better at treating it and controlling it, they're living longer lives, gratefully. But with age, as you know, then there's a higher incidence of cancer. So these patients are, they're not immune to cancer, right? Just like anybody else can also get cancer. But then we've kind of don't have the greatest data on this pretty sizable population. MS, as we all know, is the most common autoimmune disease affecting the central nervous system. So that's the gap in the knowledge that this study particularly is trying to identify or answer.
But we think of chemotherapy as the usual treatment for cancer. We think of those as okay for people with MS. Actually, we use some of them to actually treat MS, right?
That's right. Yeah, we do. There are several, but we've used them, to leverage their properties against the immune system. But this is a particularly newer kind, right? That's been, more and more popular in the last 10 years, and as you mentioned, increasingly more popular and even used as first line. Not even having failed other lines of chemotherapy, but let's just go right off the bat with what we know. But it's a relatively data-free zone in that there are a few small studies that have looked at this, but people tend to publish the worst case scenario. They like, oh, I remember I had this one patient that had MS and then started on Keytruda and that had a horrible outcome, and then that gets published as a case report. Or we have other people contributing handfuls of patients, but we have not yet had even a larger study, even if it's not even if it's retrospective, meaning we're looking back in the history of their treatment as to what actually happened. We don't even have large studies to guide our decision making on that.
So when we don't have large studies, what we need to do is we need to work as colleagues, and we need to work together to fill in those information gaps. And actually, in about the same time that I started doing these videos for people with multiple sclerosis, I also started an organization, and it is now made up of over 1,300 neurologists. It's called the Medical Partnership for MS Plus, MP4MS Plus. And in that organization, we've actually done some other research. We published and presented the largest case series of alternate dosing of fingolimod. So fingolimod, that was the first oral medication for MS, also called Gilenya. Now it's thankfully generic. And we actually looked at not just giving it every day, but giving it every other day or every third day. We also looked at another medication called leflunomide, which is related to a medicine that's approved for MS called teriflunomide or Aubagio, which also, thankfully, is now generic. But then the question came up, can we look at this question? Can we look at the question of ICIs, of immune checkpoint inhibitors in people with multiple sclerosis, not just look for the worst cases, tell people, look at all your people with MS who go on these medicines and what happens. And so when we did that, we found 7 institutions that wanted to actually give us information. Tell me more about the institutions that decided that they would take part in this study.
Yeah, absolutely. And first of all, I would have to commend you as well for having this organization, because it really allows us to do the important science, because as when you get into a bit more of the granular details or subsets of patients, they have MS and then they get cancer and then they get this newer line of treatment. Not all of the medical centers across the country really have tons of patients that we can study. So to get meaningful data and large enough samples to make conclusions that we can then apply in practice, we really do have to pool our numbers together. So that's been a really, really great experience getting to work with all of the people across the country. So yeah, I think the major centers so far that have that have contributed data so far, and it'll kind of be an ongoing process as well, is Mass General Brigham, so MGH, and Brigham and Women's Hospital in Boston, my home institution. We also have NYU, we have Johns Hopkins, we have Stanford, we have University of Colorado, we have Stony Brook, and a few others in the works. But pulling all of our resources together and also systematically asking the question, if you look at our charts list, patients with pre-existing MS diagnosis that get cancer and then have this at least one dose of this immune checkpoint inhibitor or ICI, then we pull all those out from our electronic medical records, and then you look at the charts and see what information we can glean about their medical history, their MS history, their cancer history, and what the outcomes are. And we're specifically looking, as you mentioned, at the rate of MS disease activity, so not necessarily just relapse, but to keep the question as broad as possible, looking at, is there any activity in terms of just MRI imaging? So are there just new lesions that show up in the brain that maybe they're not symptomatic, but it shows some kind of maybe progression, or reactivation of the disease? Or is there clinical activity, meaning they have a clear-cut symptom, their walking is worse or their eyes are worse, and there's a lesion to correspond to that? So this is the major question that we asked, that within a year of their treatment on checkpoint inhibitors, because we have data to suggest that the majority of the immune-related adverse events or bad side effects, whether it's relapse or flares of their autoimmune disease that's already there, or a new immune side effect, happens typically after the first dose, but within the first year of the treatment. So we looked mostly at that window.
And before this data came out, and one of the reasons why it's going to be a plenary session at the American Academy of Neurology is that before this, the largest series came out not that long ago. It was from France, and this series I think is more than 3 times larger. How
Yeah,
many
so
people? How many people are involved? How many people with MS did we find who
yeah.
also received ICIs?
Yeah, we found 65. And for
Okay.
comparison, the prior case series that you mentioned from France had 18, and the one before that, also from our home institution, was 16. So this is, yeah, many more, fold greater than that, which is really awesome.
And so, what did you find at the end? Was it dangerous for people with MS to take these ICIs, or could people with MS get the same sort of cancer treatment that people without MS get?
Yeah, I mean, so we reassuringly and thankfully found in our population, and I'll kind of get into a little bit of the nitty-gritty about that, but of the 65 patients, only 2 of them experienced any MS disease activity. And
Oh,
one of them just really only had an MRI lesion, no symptoms whatsoever. And the other had some symptoms as well as lesions. Her gait got a bit worse, but she'd responded really well to steroids and dramatically got better and was not impacting the care in the long term. So what it's a little bit important to take the context of the characteristics or kind of basically the demographics of our data, who are these people that we have? And on average, they tended to be older. So out of the 65 patients we had, on average, they were about 66 years old. So definitely over the age of 60. And it's a phenomenon that, we've seen in the field and many of you may know, but with age, the immune system does tend to quiet down a bit. It's a phenomenon called immunosenescence. And in patients with multiple sclerosis, we've seen that they tend to have fewer relapses and just lower MS disease activity, whether or not they're on any disease modifying treatment. It tends to not be as big of a disease burden as in the younger patients. So in our population of older patients that were accordingly quite far out from their last disease activity, so on average they're about a decade out from their last flare, we found that the risk of relapse or the rate of relapse to be quite low, very low. And moreover, we also looked at neurologic immune adverse events or other side effects that were not MS or, not
yeah.
MS related phenomena. Because this is important too, because you think about it, hypothetically, you're like, okay, they have a brain related autoimmune condition. You're going to unlock that immune system. Maybe it'll attack the brain more because there's something about the brain that's a little bit, more sensitive in this particular person. So we're looking at, are there neurologic side effects that are more common in these? And again, reassuringly, we found only 3 of the 65 had these effects, which compared to other reports are in the range of the general population. So anyone else that gets an ICI has similar risk or rate of getting these neurologic side effects as well, which is really awesome because having this neurologic autoimmune disease doesn't make you more likely to have bad neurologic side effects. And these can be pretty severe or debilitating. If you get something like encephalitis that just changes, the way you perceive the world and you're completely out of it and can have seizures and really can be really scary. So that also, I think, is a really, positive result. But taken together, I think what's been really great and I think would be really powerful and empowering for us as providers, as neurologists, but also as consultants to oncologists, is that the MS or the multiple sclerosis was not their biggest problem, and that that diagnosis did not make them at higher risk for having, their severe relapses or worsening neurologic side effects. So that we believe that at least, especially in older patients who are more likely to get cancer and have worse outcomes from cancer progression, that the diagnosis of MS should not prevent them from getting the treatment that they need. And they should be considered even early on in the disease course of the cancer. And it might be more helpful in achieving remission or saving lives.
This is really important, not just for people who have cancer or people who are on these ICIs or want their doctor wants them to be on it. But I think it's important in general for people with multiple sclerosis, because having MS, you wonder about two things. One is, do you have a different amount of a disease than the regular population? And then, are the treatments safe? Are they safe because of your MS? And are they safe because you're also on strong disease modifying therapies? And so what we looked at here was we were able to see that looking at a therapy that many people used to think maybe isn't good for people with MS, and they may have delayed treatment of their cancer, it actually looks like it's pretty okay for people with MS.
Yeah, and I think that that is the crux of it, because we found, of maybe 2 or 5 patients, 2 with relapses or disease activity, and 5 overall with some kind of neurologic event of the 65, versus many more patients than that who got, were unfortunately died over the course of their disease, or lost functional status, and that they were no longer able to, what we measured as ability to walk without support. So much more progressed to that end. And but the main driver, this is the number is much more than the 5 that had any kind of neurologic activity. I think, again, highlighting that this primarily should be an oncological or like cancer-related decision-making process, and that from our perspective, that the diagnosis of MS is not what we call in medicine a contraindication, meaning like, they should not be getting this, and it's a strong recommendation that they not get this treatment. I do think that it highlights another thing in that, we've had studies before that have shown, that patients, that get checkpoint inhibitors or that with other autoimmune diseases have up to half of them experience relapses, as minor as they may be, experience relapse of their autoimmune condition. But the key to these studies is that they're mostly in these what we call like systemic or other autoimmune diseases that you mentioned, like psoriatic arthritis or rheumatoid arthritis or Crohn's and things like this that are that don't affect, in this explicit sense, the nervous system. But the data were really lacking when it came to multiple sclerosis, and also, MP4MS, MS plus, the other conditions as well, which, things like neuromyelitis optica or MOGAD, which remains an active avenue of research, and we'll be pursuing that as well. Thanks again to this coalition that we have here.
Well, Dr. Rajarajan, I want to thank you so much. If there's even just one person with multiple sclerosis or a family member of someone with MS who unfortunately has cancer and their doctor is hesitating about putting them onto an ICI, maybe they can take this video and show it to their oncologist, and we can have a real conversation. I want to thank you so much for joining us, and I want to thank you back home.